On today's episode, we're going to be talking about part two in our series about recurrent pregnancy loss. For those of you who are interested, part one is episode 51, so you can check that out.
In this episode, we're going to be covering the testing options as well as the management options for recurrent pregnancy loss. I have to admit the testing options for recurrent pregnancy loss are complicated or complex or difficult. I don't know how many more adjectives I can use to convey the fact that it's not straightforward. As a matter of fact, different fertility specialists may have a slightly different panel for investigating for recurrent pregnancy loss. And the guidelines, which we're going to talk about, are really very restrictive in that there are a lot of tests that people hear about, that people request, that are actually not recommended in the guidelines.
I'll also say that my kind of go to tests have also changed over time with new knowledge and new research and the new guidelines as well. So that's another thing. But I mean, the number one thing that I will always tell people before we kind of plunge into testing for recurrent pregnancy loss, testing for RPL, is that, doing all these testing does not guarantee that you're going to find an answer, unfortunately. I will often tell patients that, even when we do all the tests, more than half the time, we may not come up with a specific answer. There may not be that like aha moment. And that's something to be very mindful of as well as you're thinking about these things. So I always offer the tests, but I do always warn patients that everything may come back normal, but that there are still options after that.
Yeah, and I cannot stress that enough because there are so many patients that come to me. It takes about, I don't know, 3 months to see me. And they tell me, yeah, we had a miscarriage 6 months ago and we stopped trying because we
Mm.
want to wait to see you and we want to wait for all the tests and we want to wait for you to tell us what's wrong before we start trying again. And then that's at the time when I have the conversation. And most exactly like you're saying, most of the time we don't find anything. So I don't recommend that people stop trying after a miscarriage, waiting for those answers, because most of the time we don't have a specific answer. And we're going to talk in this episode about prognosis, like what happens if you had recurrent pregnancy loss? What are your chances of still being able to take home a baby?
Mhm.
Before we start talking about testing options, a good question to address is when exactly do we do testing for recurrent pregnancy loss? In order to determine this, it's important to consider the definition of recurrent pregnancy loss. From the point of view of the likelihood of finding abnormalities, we recommend testing after two or more pregnancy losses. We also take into account the age of the egg provider, the circumstances surrounding the pregnancy loss, any personal or family medical history. We want to know if there is a history of infertility, if there was a normal karyotype in the products of conceptions, because remember, we said that one of the most common causes of recurrent pregnancy loss is a chromosomal abnormality of the embryo. So if we can test the embryo and know that wasn't part of that, that is an indication to dig into other causes. And also, when the miscarriages happen after a fetal heart rate has been noted, that is also another clue that we should be looking a little deeper into causes of recurrent pregnancy loss.
All right, so let's get into some testing options here. First of all, this is going to be a super general list of testing options. And I just want to be super clear that any testing options, any tests that we're going to be ordering are going to be personalized to the patient and the specific situation. So before I have talked about any test, the first thing that I'm always going to start with is a full pregnancy history, medical history for medical issues, previous surgeries, medications, social lifestyle factors as well, and a family history. That is by far number one biggest step, which we're not going to get too deep into, but that is really where we're spending the majority of the time when we're talking to patients so that that can help us personalize what tests we're ordering. That is a huge part of that initial appointment, and testing is just kind of the next step.
Now, speaking of testing, let's start with the genetic causes. One of the main tests that we do to look at genetic causes of recurrent pregnancy loss would be parental karyotypes. Karyotypes just means doing blood work, a blood test for both the sperm and the egg contributor in order to determine if there is a chromosomal abnormality that is increasing the chances of miscarriages. Abnormal parental karyotypes are actually only found in about 1.9% of couples that have recurrent pregnancy loss. And this was illustrated in a large retrospective cohort study of 20,000 couples experienced recurrent pregnancy loss.
Now, along the same lines of genetic testing, I will often bring up with patients this idea of POC testing or product of conception testing. So let's be super clear here. Karyotypes for the sperm and egg contributor are something that can be done between pregnancies or even while somebody is pregnant. But product of conception testing is genetic testing of the pregnancy material specifically. So this is only available, this can only be done when somebody is in the midst of having a miscarriage or has a missed miscarriage where we know that the tissue needs to come out. This is only available in very specific, very certain situations in a very specific moment in time. But it is certainly a testing option. So, product of conception testing basically means that when the person has a miscarriage, either, after taking medications or things passed naturally or after surgery, you can collect some of that tissue and then that tissue can be sent off for genetic testing, looking for the number of chromosomes, looking at their general arrangement and shape and size. Now, this is not covered under OHIP as of January of 2025 when we are recording this episode. And the approximate cost is around six to $800 to be able to do the testing. It really only looks at the cause of miscarriage for that specific pregnancy, meaning that it cannot tell you whether you're at higher risk of having miscarriages. It really only answers the question of why somebody had a miscarriage for that specific pregnancy if the test comes back abnormal. The reason we look for it is because we know that the most common cause of miscarriage in general is that the pregnancy was genetically abnormal. So, this is a test that is testing specifically for that. Now, even if the pregnancy was genetically normal, it can still miscarry, and there can be many reasons why that can happen. But again, this is an option for patients who are about to have a miscarriage or are actively having a miscarriage to do some genetic testing to get some information about that specific pregnancy. But again, it is not part of a routine panel when we're talking about recurrent pregnancy loss because it is only usable in that very specific time. At Markham Fertility Center, if you're a patient and you've been diagnosed with a missed miscarriage or are experiencing miscarriage, I encourage you to reach out to your physician or physician team to speak with one of the genetic counselors to see if this is a good option for you.
Now, moving away from genetic causes, now let's look at blood clotting issues. There is something called thrombophilia. Thrombophilia refers to blood clotting disorders. You can have hereditary thrombophilias, which means something that you're born with as part of your genetic makeup, or you can have acquired thrombophilia, which is something that you've developed. In terms of hereditary thrombophilia, the European Society of Human Reproduction and Endocrinology does not recommend screening for hereditary thrombophilia. In terms of women with acquired thrombophilia, the recommendation is to screen for antiphospholipid antibodies after at least two pregnancy losses to rule out a condition called antiphospholipid antibody syndrome.
Now, another aspect of testing for recurrent pregnancy loss kind of falls under this broad umbrella I'll call hormonal testing. This is doing blood work to assess the hormonal functioning to see if that is having an impact on the risk of miscarriage. So, thyroid screening, meaning looking at a TSH level and TPO antibodies, is recommended in women with recurrent pregnancy loss, again by the same group, otherwise known as ESHRE. But assessment to look for things like PCOS and specifically testing for things like fasting insulin, fasting glucose is not recommended in women with RPL to improve the next pregnancy prognosis. Now, again, the caveat to that is that if on history or on physical exam, if I have concerns or if I have a thought that maybe somebody has some insulin resistance or is even type 2 diabetic, or I know that they're type 2 diabetic, I will do something to assess their blood sugars. But again, that is a very person to person decision. We're talking about routine, meaning that every single person would not have assessment of fasting insulin and fasting glucose. Now, another one that's kind of interesting to me anyway is looking at prolactin or talking about prolactin testing. Prolactin is a hormone that the brain makes. That's number one main role is in breast milk production. For people after they give birth, if they begin lactating, that's under the control of prolactin hormone. So, when I was going through training, certainly prolactin testing and testing of prolactin was something that we did routinely on patients with recurrent pregnancy loss. But nowadays, it's actually not recommended in women with recurrent pregnancy loss in the absence of clinical symptoms of having high prolactin, meaning that if somebody has irregular menstrual cycles or no menstrual cycles or any kind of nipple discharge, then that's when they recommend prolactin testing. But otherwise, it is not recommended routinely by ESHRE.
Now, let's dive into the anatomical causes of recurrent pregnancy loss. All women with recurrent miscarriages should be having an assessment of the uterine anatomy. The preferred method of evaluating the uterus is transvaginal 3D ultrasound, as that in itself is very sensitive and specific in picking up anatomical abnormalities of the uterus. Now, a sonohistogram is also a very accurate assessment of the anatomy of the uterus. It is more accurate than a hysterosalpingogram. Sonohistogram, which is routinely done at Markham Fertility Center, can be used to evaluate the uterine anatomy, even when a 3D ultrasound is not available. And the benefit of that is that also we can assess tubal patency at the same time. A lot of people have some fears about the sonohistogram because Google and whatnot can scare patients into how painful it is. And to be honest, for some patients, it can be very uncomfortable. But for the majority of the patients, it is less painful than they think. It involves putting a catheter inside the uterus and then putting a media solution to distend the walls of the uterus and doing a 3D reconstruction of the uterus so we can see the anatomy of the cavity of the uterus and determine if there is something in there like a septum or a fibroid that could be a cause of the recurrent pregnancy loss.
I have to say, I love a good sono. I love a great sono because I feel like it provides so much great information and it provides a great picture. And for people who are very visual, it's a great picture to show someone in terms of, okay, this is what your uterus looks like. And this is the thing that shouldn't be there. It leads to a great discussion, I think, for sono. And that's why I think it's such a great test that gives us so much great information.
For sure. Now, let's talk about the male partner's contribution or the sperm provider contribution to this puzzle of recurrent pregnancy loss. So, when it comes to recurrent miscarriages, it's recommended to assess the lifestyle of the male partners because things like paternal age, smoking, alcohol consumption, and the overall health of the sperm provider can actually have an impact on the risk of recurrent pregnancy loss. And this is something that I would say is fairly new information. I don't know if you remember Dr. Weiss at CFAS in 2024 in Vancouver. There was a great lecture about the impact of the sperm in the DNA to the health of the pregnancy and the
Mhm.
health of fetus as well. So, assessing DNA fragmentation, for example, is a test that we can do in order to determine the DNA damage status of the sperm. And there have been studies linking high levels of DNA fragmentation or high levels of DNA damage to increased risk of recurrent miscarriages.
Now, oftentimes when I'm seeing patients with recurrent pregnancy loss, the immune testing or immune factors will come up in our discussion. And it absolutely makes sense. You have a pregnancy, which is a foreign thing, a foreign body that is now inside the uterus. And we know that when there's foreign things inside of our body, the immune system will typically attack them and not allow them to stay. But what is very interesting and what's really important to remember and to acknowledge is that really the testing is generally not recommended, again, by various groups and associations who are creating these guidelines for fertility doctors and obstetrician gynecologists. So, testing is generally not recommended looking at immune testing and immune factors. Now, this includes HLA typing, except in very, very specific situations that like I've never even seen. So we're not even going to get into those details. Cytokine testing or testing of cytokines is not recommended. And again, there's insufficient evidence for testing of NK or natural killer cells. This doesn't mean that the testing is bad or that it, should not be done. It's just that it is not recommended to be done routinely for every patient coming in for assessment of recurrent pregnancy loss. And this goes back to really talking to the patients, figuring out what's going on, doing history to get an understanding, and then personalizing the testing. Also speaks to the fact that there is not a lot of research, there's not a lot of literature or studies looking at these immune factors in recurrent pregnancy loss, even though I think we all agree that logically it makes sense as something to look at and something to consider, but the literature and the studies just aren't really there.
Well, we're preparing a series of episodes on this topic. So you want to stay tuned for those.
Now, another important factor to consider when thinking about testing is cost. We've talked a lot about a lot of these tests. Now, not all of them are covered under OHIP as of January 2025. That's in the province of Ontario when we're recording this. So, that's another important factor, another thing to kind of think about when you're talking to your fertility specialist about this workup.
All right. So now let's shift our focus to prognosis because ultimately, what every patient sitting in front of us wants to know, okay, I've had three miscarriages. What is going to happen to me? What are the chances that I'm going to be able to have a live birth? That's the main question when we're seeing these patients. The number of private pregnancy losses on the chance of live birth have been investigated in a number of studies. And there was actually a great model that was developed in 2021 with data from multiple studies. It was developed by Colt and Westergaard that looked at this very question. The take home message is that the number of prior losses is, in fact, an important prognostic factor for the chance of live birth. However, age is still a really important prognostic factor. And overall, and we're going to go through some examples, overall, the prognosis is very good, even for patients that have had five miscarriages or more.
And again, this data that we're going to be talking about is looking at people who are going to attempt another pregnancy via intercourse, a spontaneous pregnancy. So, this is without any fancy testing, fancy treatments, whatever, right? So, this has nothing to do with IVF or any of that jazz. It's really just if you had these losses and then you try again, then what are the odds of success?
Yeah. So, for example, according to these models, if the egg provider is less than 35 years of age and they have one miscarriage in the past, the chances of a live birth with spontaneous conception without any intervention at age 35, it's about 80%. And at age less than 35, it goes up to about 85 to 90%.
Now, let's say that that same person is diagnosed with recurrent pregnancy loss. So maybe they've had three previous losses. With three previous losses at the age of 35, the chance of that subsequent pregnancy, so pregnancy number four, continuing on to get to term, is upwards of about 65 to 70%.
And even somebody who has had five miscarriages or more at 30 years of age, for example, the chances of live birth after five miscarriages, it's about 55%. And that does drop at age 35 to about 45%. And it continues to drop as the age of the egg provider increases.
So let's shift gears again a little bit here and talk about what I think is the most hopeful part of this discussion in terms of management options. If somebody is experiencing recurrent pregnancy loss, what can we actually do to try and minimize the risk or mitigate the risk of another miscarriage? Going back to the guidelines that were put out by ESHRE, women with recurrent miscarriages should be advised to maintain a healthy BMI, to quit smoking, to limit alcohol, and to limit caffeine to less than 200 milligrams per day. And so, this is a recommendation coming out of the British Journal of Obstetrics and Gynecology. It's important to note that there's really no clear evidence or study to show that if you do this, that you will actually have a lower chance of miscarriage. However, we know that all of these things can be associated with negative pregnancy outcomes, and they are associated with higher risk of miscarriage. And therefore, we can infer that they're probably related to recurrent pregnancy loss. And so that this is general good guidance for patients who are trying to minimize their risk of another miscarriage.
One of the comments that I hear often when talking to couples with recurrent pregnancy loss is the notion of, well, I don't have problems getting pregnant. I have problems staying pregnant. Therefore, I do not need IVF. And the value of doing IVF as one of the management options in recurrent pregnancy loss is the ability to do pre implantation genetic testing on the embryos and being able to transfer an embryo that has been tested to be genetically normal in order to decrease the risk of miscarriage due to chromosomal abnormalities. So, like we mentioned before, that's a very common cause of miscarriages is chromosomal abnormalities. We know these abnormalities increase with advanced reproductive age. So, for people who are having recurrent miscarriages who might be a little bit older, especially older than 35, IVF with pre-implantation genetic testing can increase the chances of a live birth by transferring an embryo that has been chromosomally normal into the uterus.
IVF with pre implantation genetic testing, specifically looking at structural rearrangements or BGTSR, is also the recommendation for patients who are having recurrent pregnancy loss or who know that they are carriers of a balanced translocation, which is another known genetic cause of recurrent pregnancy loss. Much less common for sure in the general population, but certainly when patients have a translocation, either the person contributing the sperm or the egg, then doing IVF with PGT, specifically SR for those structural rearrangements, is recommended to figure out which embryos are the ones that have the best chance of success so that we can get those in faster and get you a happy, healthy pregnancy faster.
And if you want to know more about IVF and specifically PGT, refer back to episode 30, where our genetic counselor Diane explains the ins and out of pre-implantation genetic testing.
When something is found on imaging, when there's concern about anatomical causes that may be contributing to a higher risk of recurrent pregnancy loss, then that's when we talk about things like surgical interventions. For instance, it could be something like removing a uterine septum or uterine septoplasty or removing uterine fibroids, which is known as a myomectomy. And this can significantly improve outcomes, of course, depending on the specific situation.
If antiphospholipid antibody syndrome has been diagnosed as part of the investigations and the testing for recurrent pregnancy loss, then the treatment there would be the use of blood thinners such as low dose aspirin or low molecular weight heparin. For people that have unexplained recurrent pregnancy loss, lifestyle factors modifications such as quitting smoking, reducing alcohol intake, eliminating toxins, all of the things can make a big difference in the chances of live birth.
So let's talk about progesterone.
Oh, my favorite hormone.
Let's talk about progesterone. I have to say, it may be my favorite hormone to prescribe. It's my least favorite hormone when it's like high in my own body,
Oh,
but that's a
yes.
whole other
Yes.
story.
Let's not talk about my luteal phase right now, please.
Yeah.
So true.
Mm. Back on track here. The reason why I say progesterone is a big topic is because I think this one comes up a lot. I would say that out in the general family medicine world or in the general OB/GYN world, many patients with recurrent pregnancy loss, it may be suggested to them to take progesterone to quote unquote help support a pregnancy. And oftentimes they may be also advised to start a low dose aspirin, like a 81 milligram of aspirin daily. But I think it's really important for us to talk about, like, why the progesterone and what does it actually do and does it actually work?
The effect of progesterone, both vaginal and oral, has been studied in women with unexplained recurrent pregnancy loss. And the different studies' conclusions vary significantly. For example, the guideline developing group recommended not to prescribe progesterone in women with unexplained recurrent pregnancy loss based on the published findings of the PROMISE trial, which was published in 2015.
The PROMISE trial was a really big, multi center, double blind, placebo controlled, randomized trial. It was actually published in the New England Journal of Medicine. And in the study, they investigated vaginal progesterone as a treatment to improve live births in women with unexplained recurrent pregnancy loss. This is a study that was published in 2015. People in the study were randomized, meaning that they were kind of allotted randomly to two different groups. One group was taking a daily vaginal suppository of progesterone, And then the other group was taking a placebo, meaning that there was no medicine in there. And they started from the time soon after they had a positive urinary pregnancy test up until 6 weeks of pregnancy. And they continued through to 12 weeks of pregnancy. And in the study, they found no difference in the live birth rate in the progesterone group versus the placebo group. Again, worth noting though, the pregnancy rates, the ongoing rate of pregnancy to live birth is actually really high in both groups. So even if people were on progesterone, 66% of pregnancies continued to live birth. And the placebo group, over 63% continued to live birth.
Now, it's important to know that there is very little harm to supplementing with progesterone, even if the studies suggest that there's not a significant benefit. Like everything else in fertility, we are trying our best to improve our patient outcomes. Sometimes we have imperfect information, and we do use progesterone supplementation in people with recurrent pregnancy loss, even if there is no overt vaginal bleeding, because we want to do everything that we can to improve their outcomes. And while the evidence is not strong that it makes a big, significant difference, we know that there's very little risk and a potential benefit.
At the end of the day, I think what we basically just keep saying over and over again in this episode is that a personalized approach is key. Recurrent pregnancy loss, RPL, is such a broad topic. It's practically a whole fertility textbook in terms of the different causes and treatments and things that can be going on. And so, really, what works for one person might not work for another. And this is why having that relationship with a fertility specialist who is trying to look at all of the things and to give you all the evidence and doing all the testing is really helpful. And that's really the key place to start.
Now, we cannot possibly end this episode without talking about the incredible emotional toll of recurrent pregnancy loss. Patients experience grief, guilt, anxiety, so much anxiety when they're pregnant again. A lot of people are like, hey, you're pregnant, you should be happy. And they just can't get over their past experiences, which is totally understandable. I speak from my professional experience because I have supported many patients with recurrent pregnancy loss, and also from personal experiences because I had 5 miscarriages before I had my last child, who is now 7 years of age. So, certainly, it's important to give yourself some grace, give yourself some compassion. We've said again and again, but miscarriages are not your fault. Recurrent pregnancy loss is not your fault.
I mean, you said it earlier in the episode that one miscarriage is one too many, which is absolutely true. But if you are experiencing a miscarriage or experiencing recurrent miscarriages, apart from giving yourself the grace and giving yourself some space and some flexibility, sometimes you need some help. And so this is where therapy or support groups can really provide a much needed space to process your feelings and to connect with others who understand the situation that you're in and who understand what you're experiencing. Because miscarriages and recurrent pregnancy loss are, in a way, a silent diagnosis. It's not something that somebody can see about you. They may not know that you're experiencing it. In a way, that makes it much harder to process. It makes it much more difficult to have the people who are in your world know that there is something going on or that something is up. And so, I always recommend patients to think about therapy, psychologist, counselor, social worker, etc., and or a support group is a great place to start.
The last thing that I want to leave you with is that while, of course, it's a very challenging journey, you have heard in this podcast, it's not very clear what kind of investigations to do. Many times we don't find specific answers. And a lot of the studies have come up short, finding something that can really make a big difference. The reality is that many couples, actually the majority of couples, do go on to have a successful pregnancy with proper care, support, and the right fertility clinic behind you.
If you're somebody who is experiencing multiple miscarriages, reach out, find a fertility doctor, start looking at the testing and go from there. If you're interested in more information about miscarriages in general, you can check out episode 43 and 46 of this podcast. And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at myconfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss.
Music from Mixkit, Life is a Dream by Michael Ramirez C.
My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.